Awesome. Well, thanks guys for having us today. Hopefully this provides a little bit of insight to the cardiology APP group as a whole of how best to refer to advanced heart failure when patients um, are appropriate. And we'll kind of go over today what the definition of appropriate is and kind of give you an introduction to our team. My name is Mike Shelley. I'm the new program manager of the Advanced Heart Failure team at Maine Medical Center, specifically focusing on LVAD and transplant. I'm an acute care nurse practitioner. I work in the CTICU per diem. I was there full time when I moved to Maine about 2 years ago, and previously was in Baltimore, Maryland, working in a CTICU as well with LVAD and transplant patients. And then I'll let Lauren introduce herself, another valuable asset to our team.
Hi, I'm Lauren Vickerson. I'm a nurse practitioner. I've been with the Advanced Heart Failure team for 5 years, primarily with VAD. And in the last couple of months, I've been training towards the transplant side of things. Prior to this, I was in family medicine for a couple years as APP. And then prior to that, I worked for many years as an RN, mostly in the emergency department.
Cool. Thanks, Lauren. So a couple objectives. There's a lot of slides here. I'm going to try to burn through most of them within the first 40 minutes. Andrea, do we have an hour?
Yes, we have an hour.
Great. And then hopefully we have some time for questions at the end, which I think is the most important part of this. I think the slide deck's like 50 slides long, but most of them are filler. So hopefully we can get through a little bit faster than that. So for the objectives for today, we want to talk about just in general, an overview of opportunities in advanced cardiac therapies within our advanced heart failure population. Furthermore, determine how to identify those patients that are appropriate for advanced therapy evaluation. We'd like to give you a brief overview of LVAD therapy as a whole, and then the LVAD evaluation process at Maine Medical Center. And then additionally, learn how to place referrals to our team within advanced heart failure, and then give you just a really quick snippet of what we're all about at Maine Medical Center and an overview of our LVAD and transplant program. So let's start with opportunities within advanced heart failure. So this is a busy slide that more or less is kind of re-demonstrating what we already know as a group, that cardiac disease is one of the leading causes of death in the US, and that there's a lot of patients with heart disease. Within that subset of population, there's millions of patients with heart failure, whether it's the beginning stages of a heart failure or end stage heart failure. And then really this picture on the right really just drills down to those patients that could be better served by advanced cardiac therapies, specifically those patients with class 3B or 4 heart failure with an EF less than 25%, who are also excluded for end organ failure, anticoagulation intolerance, psychosocial risks, patient refusal, and economic burden. So this 62,000 number captures those potential patients, the number of patients in the United States who could benefit from some sort of advanced therapy. And then at the end of the day, really what this picture's trying to sum up is that those that are appropriate for advanced cardiac therapies, only a very small proportion of those patients are getting those. Specifically with this little circle graph, just saying that we implant between 4,000 and 5,000 LVADs per year, which is 6 to 8% of patients, which would be appropriate for advanced cardiac therapies. And then really, I think importantly, summing up here on the left, kind of added into this picture, is that hundreds of thousands of people die every year with heart failure, some of those which could be benefited from advanced cardiac therapies. So yes, LVAD is one portion, piece of the puzzle, to kind of bridge those patients that we could capture with advanced heart failure that could benefit from advanced cardiac therapies. But there's additionally transplant. But the issue with transplant is there's only so many organs to go around. So although there's been a steady incline in the number of patients that have been transplanted in the last couple of decades, there's a really large gap between those patients that could be best served with some sort of advanced therapy, whether it be LVAD or transplant. And since transplant's really the limiting factor, LVAD's an area where we can kind of utilize getting patients through until they are either appropriate for a heart transplant, or LVAD's the appropriate therapy for them to continue with. And then this is just another pie graph demonstrating that almost 90% of patients that could be identified in advance from advanced cardiac therapies are not receiving treatment. So within that, even aside from advanced cardiac therapies, those patients that are receiving awesome medical therapy on advanced heart failure, a large significant proportion of those patients still die every year. Almost 50% of survival is only about 50% for 2 years or 1 year for patients with advanced heart failure, and it's worse for those who see a heart failure hospitalization per year. That survival's only 50% at 1 year. So this has been noted to be such a significant finding, and mortality is high, that our newest AHA, ACC, HFSA guidelines as of 2022 recommend that those patients with advanced heart failure, specifically stage D advanced heart failure, are referred to a specialist for advanced heart failure. And that this is obviously assuming that it's within the patient's goals of care, that they want to seek extra options for their advanced heart failure. And then it also looks at, recognizing the fact that timely referral to heart failure is also a key as well. So I'll call it the art of the advanced heart failure referral. So this is a picture from the American Heart Association of just kind of what and how an advanced heart failure consult can look, or the algorithm can look. And simply enough, it starts with, does my patient have advanced heart failure? I mean, we deal with patients with heart failure a lot. It's a very vague term in terms of what heart failure is, but what does the patient with advanced heart failure look like? And this is a pictorial that we use frequently in many of our talks that the docs give when we have outreach or in-reach talks, and I borrowed it appropriately, which really shows the different classings across multiple organizations of what end-stage heart failure looks like. For the AHA and ACC, we use stage A, B, C, and D, with D being advanced heart failure. Along that spectrum, you can see patients on inotropes, those that ultimately do or don't get advanced cardiac therapies in the form of VAD or transplant, and or those patients that it's within their goals of care either before or after advanced therapies to move on to hospice and more palliative measures. Then we look at the NYHA class score, and this captures patients with NYHA 3 through 4 in that advanced heart failure stage. And then below, which is probably new to most of you guys, is Intermax profiles, which is the profiling mechanism that we use within the LVAD national database to capture or risk stratify the severity of heart failure that patients have. And that goes anywhere from Intermax level 7, which is a patient with NYHA 3 heart failure symptoms, all the way to Intermax profile 1, which is a patient that's in critical shock. This is somebody that's on ECMO. This is somebody that's on ECMO and getting worse and deteriorating. And then there's anything in between. One of the well-known things within heart failure, and specifically heart failure, is really capturing patients within the appropriate quote unquote window. This is really when patients start to slide from their class 1, 2, 3 NYHA class heart failure and really dip into that NYHA 4. And that transition can be tricky, and it can happen quick, and really catching patients early in that process is one of the more important things from our perspective when capturing patients that are appropriate for advanced therapies, and that we really want to avoid really when patients get into end stage multi-system organ failure. And really the options for those patients are quite limited after that standpoint. So really identifying trigger factors early on that make patients appropriate candidates to get to advanced heart failure referral. One of the acronyms that we use in all of our talks is I need help. I feel like it's another one of those acronyms to add to your bucket list of acronyms that you can't keep track of, but do find this quite helpful. Essentially, this acronym is used for any patient with heart failure, and it's identifying any clinical trigger that could trigger in your mind as the practitioner that a patient may be deteriorating in their heart failure status and may need an advanced heart failure referral. This was put out in 2017 through an ACC expert consensus as a decision pathway for optimizing heart failure treatment. And really, patients only with heart failure only need to check one of these boxes, in which at that point you should consider an advanced heart failure consult for your patient. So I being IV inotropes, whether that's home inotropes, milrinone, whether they're hospitalized on dobutamine, a worsening in their NYHA class score to 3B or 4, persistently elevated natriuretic peptides, and organ dysfunction with a creatinine greater than 1.8, worsening EF down to less than or equal to 35%, recent defibrillator shocks, recent hospitalization, as I mentioned earlier in that slide, with survival being less than 50% for patients that are hospitalized one time a year for heart failure. Edema or elevated PA pressures despite escalating diuretics. L is low blood pressure or high heart rate, and P is prognostic medication, and essentially it's failure of GDMT or intolerance of GDMT. So if anything, this is one of the big, I'd say, like take home slides, like post a picture in your office type of slide. And then specifically within the LVAD team criteria, we have clinical practice guidelines, and we kind of have our own subset of additional criteria that could trigger patients for LVAD evaluations. One of those that differs here out of the two that are bold is a poor CPET with a peak oxygen consumption less than 10 on patients with beta blockers, or less than 14 on patients not on beta blockers. This ends up being one of our own internal triggers to refer to ourselves when our docs are out in the clinics, a poor CPET. And then additionally, unless you guys are inpatient in the ICU, I'm not going to see this frequently, but continued requirement of a balloon pump or a temporary mechanical circulatory device as well. Now, when we talk specifically LVAD, just because the patient meets those previous criteria, it doesn't mean that there's not contraindications, and doesn't mean there's not inappropriate patients, because there absolutely are patients that despite looking like their heart's sick enough for some sort of advanced cardiac therapy, their overall health picture is not well enough that would ultimately lead to a poor outcome if they went down either of those pathways. Really, things related to end-stage multisystem organ failure being irreversible hepatic, renal, or neurological disease, patients with acute valvular infectious endocarditis, those with an internal infection of an AICD or pacemaker with bacteremia, medical non-adherence, and severe psychosocial limitations. Those end up being more of our absolute contraindications. And then other things that just make us pause, but aren't complete contraindications, are age greater than 80, malnutrition, musculoskeletal disease, active systemic infection, untreated malignancy, severe PVD, substance abuse, impaired cognitive dysfunction, unmanaged psychiatric disorder, and lack of social support. All of these are really gray areas, as any of us will be open and speak about. But as a whole, these are areas that we try to focus on when doing an eval. So I've identified my patient as a patient that may have advanced heart failure and may have an appropriate need for an advanced heart failure referral. And some of the reason that we like to see these patients within our clinics is just because we can go a step further with advanced heart failure and have a little bit more time to focus on that specific illness. more so than you guys that I'm sure are burdened with many other issues within the patients. So we can focus and drill down a little bit more on etiology, as Lauren will speak to, and kind of name drop our cardiologists. We have 7 heart failure cardiologists that kind of have a specific specialty niche area that they focus on, whether it's pulmonary hypertension or HOCM. These are all subset areas where our team can really bring some value added. They really focus on GDMT initiation and titration, and solely managing that. When it gets into LVAD evaluation, we really get into advanced directives and goals of care discussions, and we have a great palliative care team on that team that can assist with having those difficult conversations, can specifically focus on advanced directives, can continue with heart failure and comorbidity management, assess prognosis, and really get people into more higher level clinical testing, whether it's CPETs, left heart caths, right heart caths, specific echoes. And then additionally, once they make it to the heart failure referral process, we can discuss whether or not additional therapeutic options are appropriate, in which LVAD and heart transplant are just 2 options within that, but those that we specialize in. So now I will hand it over to Lauren to chat a little bit more specifically about our team and what the LVAD evaluation process looks like at Maine Medical Center.
Thanks, Mike. So these are the 3 pumps that we have the most experience with here at Maine Medical Center. The HeartMate 2 all the way over on the left there, the HVAD, and the HeartMate 3. The HeartMate 2 is really being phased out. As I'll explain in a little bit, the outcomes have been better with the HeartMate 3. So we're only implanting the HeartMate 3 at Maine Medical Center right now. You may experience some patients that still have the HeartMate 2. Right now, we have just 1 patient in our program that still has a HeartMate 2. But there may be some other, the other patients that are managed by other programs that may end up in our hospital. The HVAD is no longer being implanted. It's been removed from the market. However, we do still have 1 patient in our program that has the HVAD. That's just it's a pump that's made by a different company, basically. So our workhorse is the HeartMate 3, which is displayed on this slide here. It's a centrifugal flow pump. And as I said, the HeartMate 2 and hardware are no longer being implanted at Maine Medical Center. So indications for use, you'll hear a couple different phrases: short-term use or long-term use. Short-term, the old phrase is bridge to transplant. So these are folks that are using the pump to get to a place where they can be transplanted, whether they're listed and waiting, or they need to jump through some hoops to get listed. They're using the pump to survive to transplant. And then there's long-term use or destination therapy. These are patients who either don't want a transplant for some reason or don't qualify for a transplant. And, for the short-term use, they have to have non-reversible left heart failure. These folks, as Mike said previously, are at an imminent risk of death. Their mortality is very high. And they have to be a candidate for cardiac transplant. To be considered a bridge to transplant, you actually have to be listed for transplant at a transplant center. And then long-term, these are folks with advanced heart failure. They have to have an EF of less than 25%, and be inotrope dependent or have a cardiac index of less than 2.2 and have failed medical therapy 45 of the last 60 days, or have had advanced heart failure for at least 14 days and are in critical care on a balloon pump or temporary mechanical support. And these people, are implanted in the hospital and then usually spend about 2 weeks with us recovering, and then are on their way and can live pretty full lives outside of the hospital. And it just says, these folks, if they have to be transported, they can be transported by ground. Sometimes they are flown, or depending on their critical care status. But next slide. The Momentum 3 trial was a trial that was started in 2018. It enrolled just over 1,000 patients, and it compared outcomes between the older axial flow pumps, so that's like a HeartMate 2, to the newer centrifugal pumps, which is the HeartMate 3. So the HeartMate 3 really came out on top in this trial, basically. And you can see that the survival at 2 years with the HeartMate 3 LVAD is 83%. Which is just above the 2-year survival of heart transplant, which is considered sort of the gold standard. So it's really rivaling heart transplant really in the short term. And then you can see underneath there, the older pumps, their survival were not quite as great. The bottom two there are really much older pumps that you probably have not seen in practice in a long time. The other thing that the Momentum 3 trial showed is that the people with the HeartMate 3 are really thriving, basically. So they have improved functional status and quality of life. I think sometimes this can get a little skewed for those of us who practice a lot in the hospital setting, because we only see patients when they're not doing well, and they're admitted for a complication. But overall, our patients with LVADs have improved 6-minute walk times. Their symptoms are significantly reduced. The two graphs on the right there are quality of life surveys that we give our patients, intervals afterward, before and after. And basically, this is just showing that their quality of life as rated by themselves improves after they've received the HeartMate 3. So this just was recently published. The Momentum 3 has followed these patients, and we just reached the 5-year mark. And I don't know if it says it on this slide, or I guess it doesn't. Next slide, maybe. They just published the 5-year survival for the HeartMate 3. It's just about 60%, which is pretty phenomenal. And so because of these findings, the LVAD therapy has been given a 1A recommendation, meaning that the benefits significantly outweigh the risks of implant. So here's my slide. I got ahead of myself. Patients with the HeartMate 3 LVAD have a 5-year survival of almost 60%. And in a patient population who otherwise would likely not survive past 9 months to 1 year. So just in summary, the HeartMate 3 is a proven life extending therapy with a median survival exceeding 5 years in patients with advanced heart failure. Like we said, the 5-year survival rate is nearly 60% with the HeartMate 3. And it's comparable to the higher risk transplant population. If you do refer to us, you can have confidence that patients evaluated for the HeartMate 3 can gain access to this long-term life prolonging therapy. So the evaluation at Maine Medical Center, this can be done either inpatient or outpatient. Often we try to get it done inpatient just because it's a lot of moving parts, a lot of specialties to see. So we can get it done in the hospital in a few days, or I'd say 2 to 3 days is the typical time frame inpatient, whereas outpatient, it takes much longer. And sometimes these patients don't have that much time to do a lengthy evaluation. So the evaluation includes a multidisciplinary team. They'll meet one of our VAD coordinators who focuses more on the psychosocial aspects of LVAD therapy. They'll meet with the surgeon, a social worker who looks at insurance and financial. They look at home safety. They meet with psychiatry, who evaluates mental health aspects of the impact that LVAD will have on their mental health. As we know, depression is a significant comorbidity in heart failure. So a good psychiatric evaluation is always super important for these patients. They meet with our palliative care team. This is their introduction to palliative care, and then palliative care follows along with them throughout their course if they do end up getting an LVAD. They meet with physical and occupational therapy. They have extensive testing, including right and left heart caths, echo, EKG. They're going to get a chest CT. If they're over the age of 70, we do a head CT to look for prior stroke. They get a Panorex to evaluate dental infection if that needs to be taken care of prior to surgery, abdominal ultrasound, carotid ultrasound, and ABIs to look at vascular disease, chest X-ray. Females over 40 get a mammogram. We more recently have requested patients be up to date on their colonoscopy because GI bleeding is a significant risk after surgery for LVAD patients. CPET, that gives us a risk stratification, pulmonary function tests. Severe respiratory disease can exclude them from LVAD candidacy, so we do get pulmonary function tests. Like I said, we can do this inpatient, or we do have a clinic here. We see patients 3 days a week on PTD. There's a list of all of our doctors. You're probably familiar with most of those names. Dr. Link and Dr. Kennel are starting with us this summer. Dr. Link practiced with us previously. If you recognize that name, he's coming back, which is a wonderful thing for our program. And then, like Mike said, each one of these folks does have sort of a subspecialty within heart failure that brings like a different twist to our team, a different set of expertise. But overall, I think we've got a pretty great team. Next slide. So these are all our labs. We get significant amount of labs, just looking for comorbidities that might make their survival after implant less. And then all the ones with a little star, we generally only do if we think the patient is going to move on to transplant. We don't get all the infectious disease workup for folks that are going to be destination therapy. Next slide. I talked about this a little bit already, but this is our multidisciplinary team. And then on an as needed basis, we might consult some other specialties depending on the patient's needs. Nutrition is something that we've really sort of focused on a little bit more lately because we found that it can make a significant difference in these patients going into surgery with optimal nutritional status. It can make a huge difference in their recovery. And then, of course, any specialty that we need looking into the case ahead of time, we'll consult. Commonly consult GI or EP, infectious disease we work with very closely as well. Next slide.
Awesome.
I think I'm
Thanks, Lauren.
passing it over to Mike here.
Yeah. So the referral itself, kind of the whole point of this lecture, that was all the prelude to this. First, as I kind of already mentioned, really step one is identifying appropriate patients to refer. Point you back in the direction of I need help to assist with that process of patient identification. And then secondly, placing the referral. Honestly, regardless of which practice you're in, whether you're inpatient or outpatient, if you type in heart failure consult, something will pop up for you to refer to us. But as I'm going to spend the next couple of slides, I'm going to talk about this program InView, which we've launched recently, which is helping identify essentially patients that have these criteria. And then essentially Epic's, whether you've experienced this yet or not, but is essentially BPA prompting you to put in a referral in the first place. So it's kind of taking some of the stress or legwork off of your plate to really have to focus on identifying, because the program's kind of identifying for you and just essentially leaving for you to place the referral. So it's assisting with that. So talking about InView is really a population health program that the cardiovascular service line at Maine Med has taken on within the last year. It's been about a year-long process. It's gone through significant steps to get off the ground and get approval through the hospital as well as the main health system as well, and essentially get buy-in from all of the providers to participate in the launching of InView. And essentially the hierarchy goals are to identify patients earlier in their disease progression. So you catch patients within that window or before that window, before they deteriorate, and essentially not losing patients in our own system that could benefit from our services. Some of the portion of this is to help with service line growth and expand the service line within Maine Medical Center. And then the program itself embeds real-time automated workflows during point of care to make your job hopefully a little bit easier. Although as a provider at the bedside, I understand that BPAs can be a little bit of a nuisance. But hopefully after this talk, you can kind of see maybe the importance of, at least from our perspective, of how we view this as important compared to maybe some other BPAs that are launched. So as a whole, this has been a cardiovascular service line approach. Heart failure, the LVAD transplant team have just essentially been a piece of the puzzle. InView is launched with the heart failure team, with structural as well as EP, and helping identify as those teams have selected criteria for their patient population. It can include TAVR, PFO ASD closure. For our team, this goes even into looking and identifying patients that may or may not be appropriate for CardioMEMS therapy. And then from an EP standpoint, just trying to capture patients that may benefit from AICDs, pacemakers, et cetera. And essentially how this works is it works just fully within the EMR. The program has full access to Epic and our data registries. And it builds registries within the EMR. It analyzes and risk stratifies patients within our patient population based on criteria that each of these subset specialties have defined. So essentially the experts within each areas have identified patients that they felt would be appropriate to have potentially referred to them. And then it goes one step further and builds interactive reports and dashboards, and then ultimately implements workflows within the EMR to interact with the provider to assist with referral placement. And ultimately, in a happy world, a patient is ultimately identified and then referred to the appropriate specialty that they would benefit from seeing. This is basically just a slide that captures all of those same things that I kind of just mentioned. Like a patient theoretically is admitted, they're screened real time from their Epic encounter, an automated order is placed, which is ultimately ordered by you guys. A patient's discharged and ultimately seen us in the heart failure clinic. These are the heart failure criteria which we have used to identify patients as heart failure referral candidates. Some of the highlight ones are greater than 2 heart failure hospital admissions in the past year, ongoing inotrope dependence, reduced EF less than 35%, hypotension with a systolic BP less than 90, AICD shock. So some of those things that we've discussed already and I need help have been some of the inclusion criteria for identifying risk factors within Epic. And then there's a bunch of other subset criteria that are heart failure specific that Dr. Coffin and the team worked on identifying. And then I'll get into this a little bit more. So ultimately, there's a couple triggers and BPAs here that aren't specific just to advanced therapies. There's an LVAD BPA, there's a transplant BPA, there's a advanced heart failure BPA, a worsening heart failure BPA, and as well as CardioMEMS. And all of those have different criteria that identify patients and try to point them and guide the clinician provider to, what therapy the patient may best benefit from. So for LVAD, we made those criteria a little bit more strict. Obviously, there's an age component that we don't want people that are too old, just because their outcome with LVAD wouldn't be that great. So we specified an age between 18 and 80. We are not a pediatric center and only focus on adults. An LVEF less than 35%. Renal function needs to be preserved as we don't have dialysis access for LVAD patients in Maine. So that ends up being one of the big contraindications, although other states and other centers are able to implant patients with LVADs that do have a renal dysfunction, as well as 1 hospital admission per year. So the LVAD criteria are a little bit more strict. This is essentially a pretty picture put together by the InView team that kind of showcases the worsening heart failure and advanced heart failure severity score. The variables are on the left here. And then essentially our team deemed that for someone to trigger as an advanced heart failure candidate, they need to meet at least 5 of these criteria on the left. And it can be a combination of any of the 5 on the left. When looking at the patient population subset within Epic, for our patients, long story short, the point of this slide is that of all of the patients within the Maine health system, only 33% of those patients in the advanced or worsening heart failure categories have visited a heart failure clinic in the past year. So essentially, this is just an opportunity evaluation slide that there's upwards of 700 patients within the health system that have not seen a heart failure doctor that would benefit from seeing a heart failure doctor. And then this is essentially just another slide showing that there's more than just one specialty group within this structural and EP, and everyone kind of has their own point of care workflows within the EMR. How these BPAs trigger in the inpatient setting versus the discharge setting versus the outpatient setting are all a little bit different. Within the inpatient setting for the heart failure group, the BPAs are put out as a passive notification within the problem list navigator. Within the discharge process from the hospital, it's an active BPA in the discharge navigator. And in the outpatient setting, InView has been launched in primary care as well as the cardiology practices, and they launch a little bit differently in each of those. In primary care, it's a passive express lane, whereas in the cardiology outpatient setting, it's a passive active express lane. This is how the navigator may or may not look for those of you that are inpatient cardiology. It looks the same for the hospitalist as it does for the cardiology group, and that you'll get this BPA within the problem list. And I think this is kind of cool with it in that it identifies that you should place an order for your patient. You have the option to not to. We would encourage you to place one. You can acknowledge a reason for whether it's not appropriate, patient declined, or defer for 24 hours if you don't want to order. But I think from the inpatient standpoint, would still require an advanced heart failure consult and page to the team in which any one of those heart failure doctors is going to answer your call. But this neatly, I feel, identifies those criteria of why your patient populated for the specific BPA that they did. In this example, the patient has an EF less than 35%, their serum sodium is less than 130, their chloride is less than 95, they have a dilated left ventricle, and they have a lactate greater than or equal to 2, and then they're not on GDMT. So essentially, I feel like that kind of helps in painting that picture when you're having that conversation on an inpatient standpoint of, like Epic notified this BPA for an advanced heart failure consult. This is my like 1 or 2 liner for my patient. These are the trigger criteria that they met, and then just continuing to have that conversation. The discharge navigator is a little bit different. It's not going to be an inpatient referral to heart failure. It is going to be an ambulatory referral to heart failure. So same idea. It's going to trigger what the patient qualified for, quote unquote, qualified for in terms of BPA. This patient triggered for heart transplant consideration based on the criteria here. And then you have the option as the provider of which ambulatory heart failure clinic to place the referral to. The options being Scarborough, Augusta, Waterville, North Conway, and Damariscotta. So whatever works best for the patient. All of our heart failure doctors have specific niche clinics that they go to. They all rotate through 22 Bramhall. However, they all go to different outpatient clinics. And then in general cardiology, similarly to the discharge flow, it is going to have the same prompt. This being in the express lane, however, in general cardiology, and then it's going to trigger or recommend a referral to one of our ambulatory heart failure clinics. For the sake of time after this, I have a neat little tip sheet, tricks and tips sheet of each specific setting that I can send out to Andrea. I'm not sure the best way to get it out to everybody, but essentially each subset group has their own different in-view referral pathway, and it's kind of neatly put on one sheet. So I can kind of send that to everybody afterwards. And then really quickly, because I want to leave at least 8 minutes for us to chat if there's any questions, just wanted to kind of give a brief overview of our program as a whole. The LVAD program's existed for a few decades at Maine Medical Center. It's seen multiple iterations with different surgeons and different devices as technologies have changed over time. We did our first LVAD implant in 1997, being one of those early generation LVADs that really confined people to the bed within the hospital. Really, at that point, I would imagine for a bridge therapy as not a bridge to nowhere. Ideally, it would have been bridge to transplant at that time. And then really in 2014, the kind of programs really relaunched again under the guidance of Dr. McGrath and Dr. Danino. And there's been significant growth. I mean, as essentially LVAD technology's changed, we've changed as well and implanted whatever the recommended technology is. And then one of the areas that I feel like we're on the forefront of, and Dr. Danino is very proud of, is, some patients do actually have myocardial recovery depending on what their etiology of their heart failure is. And they do have myocardial recovery and actually benefit from explant without additional advanced cardiac therapies. And we had one of our more recent explants after he was implanted for a couple of years. He recovered, young guy, in his 30s, and he's been without his LVAD for a couple months now and at home and doing great. So there's really a lot of research area around myocardial recovery and explant of VADs after they've been in for a while. The program has definitely grown in the last 8 or so years, since 2014 last year. The program successfully placed 19 LVADs, which put us in as the second largest program in the Northeast last year for L implant. This is just a nice little graph of LVAD implant distribution by model. As Lauren kind of alluded to in her one slide, by looking at the types of devices. The red represents HeartMate 3, which has really been the primary gold standard in LVAD therapy over the last couple of years. We had a quick boon of Heartware in 2017, 2018 before it was taken off the market. And prior to that was really HeartMate 2. And then I find this to be one of, other than quality of life, I find this is a pretty powerful slide. This is from our Intermax database registry, and this is looking at 5-year survival. The red curve is our team at Maine Medical Center, and the blue line is the national benchmark, the national standard in terms of survival. Higher is better. On the axis over here is percent survival, and our percent survival at 5 years sits around 60% compared to 50% at the national average. So I think this speaks to, as we've been growing as a team, we continue to do a very solid job and benefit patients in Maine. And then within this entire talk, I mean, there's a tendency to focus on LVAD, as that's what we focus on at Maine Medical Center. Now, although we're not a transplant center, we talk about transplant with all of our patients that are appropriate for transplant therapy. Although we're not a transplant center, we have very solid relationships with many of the programs in Boston, and any patients that are appropriate for transplant referral, we've referred directly down there. And then additionally with LVAD, patients may have relative contraindications or absolute contraindications to transplant now. However, a lot of those end up being substance misuse issues, whether it's alcohol or tobacco or marijuana, and those things can be overcome with abstinence over time. So we do, I looked at our data a few days ago, and since 2014, over half of our patients ultimately, after LVAD implant, we've been able to refer down to a Boston center and have transplanted. So that ultimately remains the gold standard, is long-term getting those patients that are appropriate to heart transplant, and that we continue to advocate for those patients in Maine and continue to have a really good relationship with these really class institutions in Boston. I can share, you guys will have this recorded version. I can also share this PowerPoint with Andrea to send to everybody. This ends up being a pretty good slide for contacting us. Feel free whenever you have a question to reach out to anybody on the team if you think anybody's appropriate for referral. If you forget how to place the referral, you don't like InView or something, but find that it's easier just to pick up the phone and call us, we're there. This is just a quick slide of the team. Dr. Danino is our surgical director. Dr. Shao is currently our medical director. She is leaving soon, and there will be a search for a new medical director. And then myself in the top right, our heart failure cardiologists on the second line, and then our APPs, our RN coordinators, our medical assistant on the team, holding up the bottom of the team. And then this, I feel like, is always a really good slide that kind of sums up LVAD. These are all LVAD patients that are doing quite well post LVAD implant. Dr. Danino and Lauren have been with the team for quite a longer time than I have, but they both say that they can't recall any single patient that we've ever implanted that regret their decision to go down this pathway of LVAD or LVAD to transplant. And I think this just kind of captures all of those happy faces that kind of made it through their difficult heart failure journey and are continuing to do well today. So with that, I think I left us a couple minutes for any pressing questions from anybody.
No, that was great, Michael. Thank you. What, and you've been here 2 years?
So I've been here 2, and I started with the advanced heart failure team in October.
Oh, okay. Yeah, do you stay in the CT surgery area primarily, or are you up on the
I'm on
heart
P2D.
side?
Yeah.
Okay. I haven't met you yet.
Well, we'll have to make that happen.
Yeah.
And you yourself, Andrew, are you on CAPS or?
Yep, CAPS. Yep.
Awesome. Okay, cool. Yeah. Great. So I can send this to you. Andrea, I'm not sure if it's best who the best facilitator is of the tip sheets. I feel like those are helpful, and I kind of flew through all of this, but just how the BPA look in Epic. I feel like that's a glance over for everybody.
Yep, send it to me and I can email it out.
Okay.
All right, any other questions, guys? All right.
All right. Well, thanks
Good
for
rest of
the
day.
hour on an early Tuesday morning after the holiday, everybody.
All right, thank you.
Great. Thanks.